Good evening, everybody. We're going to go ahead and start. People are still signing on, but I'd like to keep on time if possible. That way it leaves me some time at the end for some questions. The first few slides aren't so super important, so it'll give people time to sign on, but we might as well get started. Thank you for joining me. I'm Dr. Mary Wendel. I am the founder of Medi Tresse. We're already having technical difficulties. Okay, fixed. Good thing I have my tech person here with me. Just before we begin, just a couple of logistics here. We do have a Q&A section at the end. Hopefully we'll have some time for that. Please use the section that says Q&A and not chat. The chat we generally don't utilize. Do put your Q&A, your questions in the Q&A section. Okay, and again, important disclaimer, this is for educational purposes. This is not a consult. You know, if you feel you need more information, you know, we will have some information at the end of the webinar if you'd like to come in and be seen and have a full evaluation, which is really what my messaging is. I say it over and over and over again, and those of you who have joined me in the past have heard this over and over again. So in order to get the right treatment for you, you really need to have an in-person thorough evaluation. So let's just an introduction to me and Medi Tresse. We partnered with AP Derm about a little over a year ago as a hair loss specialty practice. We've been in business for over 10 years. AP Derm already had a number of dermatologists in place that specialize in hair loss, and we're working all together. We specialize in hair restoration with two different brands under one roof. Medi Tresse specializes in the non-surgical hair restoration for women. Northeast Hair Restoration is our group that specializes in hair transplants for men primarily, but also women. They also do non-surgical treatments for men. We have multiple locations in Massachusetts. We're in Somerville, Wellesley, Westford, Worcester, and we also have two offices in New York. I know some people are probably listening in from New York as well, an office in the city and an office in Scarsdale. So we're pretty much all over the area. We have a very experienced team on board, and our medical directors alone have had over 20 years of experience in specializing in the treatment of hair loss, both non-surgical and surgical. Within our group alone, we've done over 12,000 PRP treatments, and our surgeons have been very successful and have done over 10,000 hair transplant procedures. Usually this time of year, I do an update in the latest treatments of hair loss for men and women. I generally go to a couple of conferences that keep us updated on what's new. Because we have so many people listening today, I thought we really should talk a little bit about where the standard of care is today, and then we'll move on to new medications, updates in hair transplants, a little bit on cell regeneration therapy. We'll talk about the microbiome, which is a really hot topic. Also GLP-1s, so many patients coming in are on them, and what is the real story in regards to hair loss. And then I want to briefly just mention social media because it's an influential location where people get information that's not always necessarily accurate. I'm going to take myself off the screen and I will join you at the end here. So let's talk a little bit about what are the standard treatments. And again, this is just a brief introduction so that some of the terminology sounds familiar when we get to the newer treatments. Primarily, there are multiple causes of hair loss in men and in women. The biggest, most common one is androgenic, which for men and women is the pattern hair loss, the most typical cause. We also see in women a lot of telogen effluvium, which is excessive shedding, some traction alopecia, which is due to poor hair care practices. We do see post-cancer hair loss, and we successfully treat them as well and support them through that journey. Alopecia areata, we are seeing more of as well, which is an autoimmune disorder. There's also an entity called scarring alopecia. We don't talk about it as much. It's not as common, but it is probably one of the most distressing and difficult ones to treat because the hair follicles actually get destroyed. And so treatment and early diagnosis is incredibly important. So let's talk about androgenic alopecia. It is by far the most common cause of hair loss in men and women. In terms of our female patients, more than 80% of our patients that come in through the door have androgenic alopecia. In terms of the male patients, it's a much higher number. I listed 95% as probably closer to 99%. We do see some of the other causes of hair loss in men. It's usually in combination with the androgenic though. Androgenic alopecia represents the overwhelming majority of hair loss in both genders. It's a genetic condition. It affects both men and women, though it presents generally differently in men and women. In women, it tends to be more of a diffuse thinning over the entire top or crown, and it oftentimes can maintain the frontal hairline. In men, it usually starts in the front and tends to work its way back, receding the hairline and causing some baldness towards the back as well. It's important to understand that in men and in women, it's basically the same disease. It tends to occur with different frequency, but the underlying problem is generally the same. It's important to understand that it's a chronic progressive condition and that early treatment on both sides, men or women, with appropriate, well-studied and scientific treatments can significantly slow down the progression and in many cases restore meaningful hair density. But again, the key is an accurate diagnosis, starting treatment before too much miniaturization or loss of hair has occurred. Just a quick look at what these patterns look like for both men and women. And again, it's a combination of genetics, which we all inherit from both sides of our family. You know, everybody talks about, oh, it's my mother's father who caused me to lose my hair. No, it's a much more complicated, complex genetic situation and predisposition. Hormonal influences play a big role here, aging. In terms of the genetics, more than 50% of men will experience hair loss during their lifetime. Between 30 to 50% of women will also be affected by androgenic alopecia. It generally occurs later than men, but again, we do see young women in their early 20s coming in with androgenic. If you have family members in your hair with thinning hair, you are at risk. I always tell everybody who's sitting at the dining room table during Thanksgiving, if anybody's losing their hair, please understand you may be at risk. What actually happens is there's a conversion of testosterone in both men and women. It converts to DHT, which causes the hair follicles that are genetically susceptible to shrink progressively over time. The hairs get smaller and smaller, they get shorter and shorter, they don't grow as far or as fast, and they eventually stop growing. Aging plays a huge factor, which is why we see so much of it later on in life. With aging, there are multiple changes around the hair growth. You have a loss of collagen, you have decreased skin thickness, reduced circulation, of course, diminished nutrient absorption from the gut, and less effective stem cells, which are required for normal hair growth. Those things are just part of aging. Doesn't mean we can't do things about it, but there are multiple factors going on here. And then with women especially, the loss of estrogen as they approach and go through menopause, and the alterations in testosterone levels in both men and women can accelerate hair loss. These hormonal shifts affect the hair follicle and then the sensitivity to the DHT, which is a breakdown product of testosterone. I just want to put this chart up just for some vocabulary. So when I say these terms in the webinar, it makes sense to you. The most important thing to think about is the anagen, which is the growth phase, and it can last anywhere from 2 to 6 years. The thing that happens though with androgenic alopecia is this growth phase shortens. And women notice this, I think, more than men because they try to grow their hair long and it just won't grow that far anymore because the growth cycle shortens. It grows to a certain point and then it falls out. Men don't notice it so much because, you know, they get their hair cut more frequently, but that happens to men as well. The catagen phase is that transition phase where the hair starts to pull away from the follicle. And then the telogen phase is where it starts to rest and then eventually sheds. This is going to be an important terminology, the telogen effluvium, when we talk about GLP-1 hair loss. So what are the hair loss risk factors? We mentioned the genetics. Stress is a huge component here as well. Poor nutrition, I can't stress enough. We'll talk a bit more about that later. Any kind of illness can result in hair loss. Hormonal imbalances, as I mentioned, age, and just overall scalp and follicle health. It's important to keep that scalp healthy. I was listening to a discussion and a woman was talking about aging of our skin and then aging of the scalp. And she said, you know, in reality, our scalp is just an extension of our skin. Our skin ages, we know it happens, so does our scalp. But that doesn't mean we can't do anything about it. We can't reverse it completely, but there are things that we can do to help. So treating hair loss, the first step in treating hair loss for anybody is to get a good history, both the medical history and the hair loss history, a good physical examination, including trichoscopy, which is a magnification of the scalp to take a look at the health of the scalp and the health of the hair follicles, what's actually going on in there. Without that examination, you really don't know. And to start treatment that you can, you know, buy anywhere online over the counter, your next door neighbor, without really knowing what's going on in your scalp, you don't know what you're treating. So it's very important to have that diagnosis done by a specialist in this field. Sometimes we do blood work. Very commonly in women we do, some of the men as well. We rarely need a biopsy because usually the diagnosis is clear once we do that trichoscopy and a good exam. Keeping in mind, again, the treatment plan can vary greatly depending on the diagnosis, which can really only take place with an in-person exam. Again, I'm just going to talk about the treatments for androgenic alopecia that we know work and are beneficial. These are evidence-based scientific treatment options which have been studied for decades. So medications, yes. Do medications work? Yes, and I'll talk a little bit about that. Platelet-rich plasma, or what we do here is called optimal platelet concentration, PRP, also can help stimulate growth. Low-level laser therapy, scientifically proven to be beneficial. Supplements can be helpful. And again, they vary depending on what the underlying physical condition of the patient is, what their dietary intake has been, how well they take care of themselves, and what's going on with their life in general. This becomes an issue again with the GLP-1 weight loss. Hair transplants are effective in many men and in some women as well. It's important to understand that we rarely recommend a single treatment. These treatments all support each other and they treat things differently and they come at it from different angles. The mechanisms of action of these treatments is variable. And so when you combine treatments, they are additive. That has been proven with multiple studies. This, unfortunately, without treatment, and patients know this who come in late, this hair loss will continue to worsen over time. Early treatment is very important and personalized treatment plans is essential. Treatments vary, and what certain patients can tolerate, another patient might not. What works for one patient doesn't always work for the next, and a lot of factors play into that, and it's important to get a thorough evaluation. So let's talk a little bit about medications we know today are working. Minoxidil, a lot of people cringe when they hear that because all we had for the longest time was topical. Interestingly enough, it works, but a lot of people didn't like to use it. We've become more interested in oral treatment, which interestingly enough has been around for decades, but this is low-level minoxidil therapy. And it's very well tolerated. It does have some side effects, but usually they're minimal and can be managed easily. It's once a day and it offers convenience for patients who struggle with topical application. Most women don't like putting things on their scalp. Any kind of topical treatment generally requires you to shampoo a bit more frequently. It does leave a bit of a residue, but for some people who cannot tolerate the oral, minoxidil is still an option for them. Finasteride and dutasteride are the blockers of that DHT hormone that causes the hair to shrink. Finasteride is 1 milligram a day. Dutasteride is 0.5. They both block this 5-alpha reductase, which causes the testosterone to turn into that DHT. Dutasteride is a bit stronger, has a longer half-life. These medications are for men and only postmenopausal women. There are some significant side effects in premenopausal women and women who can become pregnant. It can affect the fetus quite seriously. So primarily it's for men and postmenopausal women. Spironolactone is a drug that's been around for a long time. A lot of women are familiar with it. It's also a DHT blocker, not as strong as the finasteride or dutasteride, but it does block that DHT, and it is an anti-androgen, which, you know, the androgens are the culprit here. This is particularly useful for women with hormonal hair loss. We see a lot of young women with what's called PCOS, which is unfortunately a disease which causes their testosterone levels to be higher, and it can drive hair loss. And spironolactone can be a good blocker, particularly since it is not safe to give finasteride or dutasteride to young women. Ketoconazole shampoo is actually a dandruff shampoo. It's the brand name is called Nizoral. It comes 1% over the counter or 2% prescription. Used weekly, it is also a DHT blocker. It also balances the scalp microbiome, which is something we're going to talk about in a little bit. It does provide some anti-inflammatory benefits. And again, it's just an added adjunct to the other treatments. PRP, or platelet-rich therapy, how it works, it utilizes your growth factors in your own blood to help stimulate the growth of stronger, thicker hair. It's been around for quite a long time. It's interesting, at the conference, we didn't talk a lot about PRP because it's standard therapy, hasn't changed very much. We know that it works. We do it a bit differently here. Not all PRP is the same, except to say that pretty much everybody does 3 to 4 treatments 1 month apart as the initial treatment plan, and then boosters every 3 to 6 months after that. It's important to understand that this is a treatment that needs to be maintained to continue the growth that you get. PRP can be used in most women with androgenic alopecia and men who have mild loss and are not yet considering a hair transplant. Recently, research has shown that PRP can significantly improve hair transplant results when started during the procedure and then continued for several months after. Again, we do it a bit differently. We still do the monthly initial series followed by the boosters, but we actually check platelet counts before every treatment. And there's a reason for that. Research has shown that the platelets, around those platelet cells, are all those growth factors which help stimulate growth. And there's also been research to support that a certain level of concentration of those platelets is what's going to make this treatment work best. We were able to determine that concentration, figure out how much PRP is going to work best for each patient depending on their blood counts. How does it work? We do simple blood tests, just like when you go to the lab. We do a platelet count prior to the treatment. The blood is centrifuged and processed. It's concentrated and then eventually injected into the scalp using fine needles. The entire treatment takes probably less than 45 minutes. There is some minimal discomfort to the needles, but we do use anesthetic, and there also is a painless option available for patients who don't tolerate the needles. Results typically become visible within 6 months, with continued improvement over 6 to 12 months. And it's important to understand the consistency is very important. The benefits need to be maintained in order for you to keep that benefit. If you go through the series and then decide to stop everything, you're going to lose that benefit, which is true of pretty much any treatment for androgenic alopecia. It only works while you're using it, which is true of most diseases. You get a medication for your blood pressure, gets under control. If you stop it, it's not going to cure it. You need to continue with treatment. Low-level laser therapy, they have been around for decades. It has shown that it can stimulate new growth in patients with androgenic alopecia in both men and women. It's not to be confused with LED lights, which are not as powerful and do not have the same benefits. All the initial studies showing benefits were used for laser-only treatments. There are some new caps and new treatments that have a combination of laser diodes and the LEDs. They generally don't work as well. They can give you some benefit, but again, we believe strongly that it should be an all laser unit. Generally, you use it every other day for 10 to 30 minutes, depending on the model. And then, supplements. Do we believe in them? Yes, I do, because so many people have significant dietary deficiencies. Again, this becomes a big issue when people are losing weight quickly. We do know that certain deficiencies in vitamins and nutrients can accelerate hair loss. We do blood work before starting PRP treatment, and really almost anybody that walks through the door, because we want to find out what is their underlying nutritional status. For myself, I don't eat meat. It's very important that I know my vitamin B12 and ferritin levels, which at times have been a little bit low. And I have androgenic alopecia. I need to keep on track of those things. We are all pretty much deficient in vitamin D. We don't get enough sunlight. I don't remember the last time I was outside. It's probably been a month for more than 5 minutes. So I also supplement with vitamin D. But there are supplements that we do recommend. And again, prior to starting any treatment, it's important to check these levels, because if your level of ferritin is extremely low, your vitamin D or B12 or any of these nutrients is low, it's going to impact the success of your treatment. Some women, we also check their hormone levels depending on if they're supplementing, and we do check testosterone levels in some women as well. Quick review of hair transplants. It's a very successful procedure. Basically, the hair follicles are removed from one section of the scalp, which is called the donor area, and replanted to another area, the recipient area. The donor area is considered quote unquote safe. The hairs back there tend to tolerate the testosterone. They're not genetically prone to get smaller. So they amazingly can be moved and they keep that strength with them. So it's not necessarily where they were growing as much as it's what kind of follicle it is. The initial type of hair transplant was called the FUT, which is the follicular unit transplant, which involves taking a strip from the back of the scalp, cutting it up into small sections. And I'm not talking about plugs, I'm talking about individual follicles, which are then transplanted to the front. Most commonly now, people are having an FUE, which is the follicular unit extraction, where they literally take the hairs out one follicle at a time and replant them to where they can grow. There is no more strip. Who benefits the most? Hair transplants are most commonly performed on men with advanced androgenic alopecia. We also perform some on women who meet certain specific criteria. The trouble with women is that it tends to be more of a diffuse loss, which makes it hard to know if the hairs are safe to transplant. But we can successfully transplant women as well. We just screen very carefully. So let's get to the new stuff. I feel like I've been rushing through very quickly. So let's talk about new things. What I just discussed was all the standard of care, what we do on a regular basis every day here, and things that have been studied and for many, some things for decades, but very carefully studied. The schedules are very important. We know where it works, and we see it here every day. The good news about hair loss, and I have to stress this, there is a lot of research going on. I'm impressed more and more every year by how much research is going on with both medical treatment as well as surgical treatment. It's very exciting. For the longest time, people were doing things without knowing that they really worked. And it was sort of, guesswork. That is not the case anymore. There's actually great research being done and some new treatments that are happening. And I think in the next 5 years, we're going to see some changes that, again, we'll probably still be using a lot of the same things we're doing now, but we'll be adding new treatments that might be working a bit better. So let's talk about some new medications. This whole page is on minoxidil. Minoxidil is not new. We've been using it topically, as I mentioned. Ideally, topical is applied twice a day. Very few people will actually commit to that, particularly women, because they don't like how it feels on their scalp. Interestingly enough, we know that with minoxidil, a certain percentage of people genetically don't respond. They don't have the minoxidil activating enzymes to make it work best. Doesn't mean it can't work at all. It just doesn't work fantastically. In the last 4 years or so, we've been using more oral minoxidil. And people are much more compliant with oral, particularly women. The doses are low and the side effects are generally very well tolerated. There are side effects. You can have headaches, you can have palpitations, excess facial hair growth, which is the thing that bothers people the most for women, some body swelling, but generally that's very rare. The most blood pressure issues can be a concern if someone's blood pressure tends to run low. But we monitor for these things. And again, 95% of people that are started on oral minoxidil stay on it. The benefit is equal or slightly greater than the topical, which is great to know, and it may be dose dependent, and I'm going to talk about that in a minute. Sublingual is not available commercially, but it actually works very quickly, and it bypasses the blood circulation, bypasses the liver metabolism, excuse me, and therefore has fewer side effects. All of these minoxidils generally take up to 6 months to see any visible benefit, but it does help. Again, sublingual, not yet commercially available, but it's being researched. The other type of a way of applying minoxidil is something called microinfusion, which is not just topical where you just lay it on there. This is actually delivered directly to the scalp. This particular group under number 4, these two physicians used an experimental use of tattoo needles to deliver these medications directly to the scalp. Minoxidil can be delivered solely, or they used it in combination of like the dutasteride, some copper peptides, and they found that there was significant improvement in growth after 6 months. These microfusions or mesotherapies tend to be used more for patients who don't respond to the typical dosing, like with the sublingual or the oral. And again, there's a small percentage of people who don't seem to respond to the typical treatments. And this is where something like a microinfusion or some of the regenerative therapies that I'm going to talk about in a minute are being utilized today, but mostly under scientific protocols, under research protocols. So, but again, this may be more of the future, particularly in patients that don't respond, our most challenging patients. Okay. Other emerging medications. This is really interesting. The VDPHL01, it doesn't even have a name yet. This is actually an extended release minoxidil, 8.5 milligrams twice a day. So that's a pretty big jump to 17 milligrams compared to the, a half a milligram to 2 milligrams that we've been using. But because it's an extended release, the hope is that the side effects won't be worse. The phase 2 studies are phase 1, 2, and 3. This just finished its phase 2 studies, and they found that there was a 3 times higher rate of improved hair density with this new extended release minoxidil compared to the oral minoxidil 5 milligrams or the topical minoxidil 5% twice daily. People are really excited about this. I'm thrilled if this is in fact going to be the case. My concern is always about side effects. The minute you increase the dose, you're more likely to have a side effect, but the hope is that the extended release formulation will make that less likely to happen. This medication is undergoing their phase 3 studies this spring, and that is probably going to take another year to look at that data, and then it'll go before the FDA to be approved if the safety profile is good. So that's exciting. Again, it's actually, it's improving the whole minoxidil scenario. We know it's a medication that works, doesn't work as well for everybody, but there are some patients who get a great response. And this may be a way of improving benefit, increasing the dose, which we do know probably improves benefit with hopefully less side effect problems. This next drug, PP405, I have no idea what it is. I couldn't find any information on it except to say that it is a topical therapy that supposedly reactivates the hair follicles that hang around the stem cells that hang around the hair follicles. Hair follicles themselves have this sac of stem cells that sit down at the bottom of the root of the hair. They are utilized to actually help grow new hair. If you can stimulate those to work and to get going and get moving, that will help stimulate growth. I don't know how it works. They listed it as a novel mechanism of action. It is also undergoing phase 3 studies beginning this spring. I'm sorry, that's a typo. It's 2026, this spring. So we'll see. It is a topical therapy. I'm a bit less enthusiastic about topical, particularly for women, because they don't like putting it on their hair. But again, if it's something that works really well, then most people would consider it. The third one, clascoterone, 5%, is actually a medication that exists already. It's used for acne, but this is an anti-androgen that blocks the DHT in the hair follicles. That's not how it works for acne, but that's what it's doing for hair. Studies show significant improvement with minimal adverse reactions. Definitely more studies need to be done to compare it to minoxidil, finasteride, dutasteride. Again, the studies have only been done on men, not studied on women. The safety profile needs to be examined for women before it gets recommended. One other whole group of medications, which is really coming to the forefront, is a whole group of medicines, a category called JAK inhibitors. Scarring alopecia, I mentioned briefly in the beginning, is a very challenging, difficult, heartbreaking type of hair loss, much more common in women than men. It is on the rise. We don't understand why. It's an autoimmune disorder. There may be some genetic as well as environmental causes. Is it something we're putting on ourselves? Is it something we're putting in ourselves? Unfortunately, the hair follicles are actually destroyed. And if it's not treated aggressively early, they disappear and you can't get them back. It can be permanent. So this whole new medication called JAK inhibitors is being used already for other types of autoimmune skin disorders like alopecia areata, vitiligo, eczema, psoriasis, and it's now being tested for scarring alopecia, which would be really a wonderful addition for treatment here. The initial studies are showing benefits in scarring alopecia with slowing progression and in some cases demonstrating regrowth. Right now, as it stands, there are no FDA-approved medications specifically for these diseases. So if these medications end up being helpful, they will be the first FDA-approved medications for this. And I'm very hopeful. This is a tough one to treat, and it's primarily women, and it can be very aggressive. And again, this is why you need to have an in-depth personal exam. You know, a person, for instance, the woman on the right, she would show up and you know, we'd be able to make that diagnosis under the trichoscopy. But a lot of women who have that degree of hair loss are buying things online, or, you know, going to the pharmacy and hoping for the best with something over the counter. And that's not going to do anything for her. She needs treatment, and we have treatment, and it usually can have some benefit, but it doesn't have the same degree of benefit as these new JAK inhibitors are probably going to have. So, okay, a little bit of update in hair transplants. The conferences that we went to talked about surgery as well as medication. A lot of the surgical updates are really more technical that I don't really want to get into, but the methodology, you know, the instrumentation, the way they actually put the hairs in place, all of that is constantly being updated and improved, which is great. In terms of what do you see, one of the biggest changes is what's called the no-shave FUE. And as I mentioned before, the FUE is you take the hairs from where they're safe to be moved, and it's primarily in the back, and they literally remove them one follicle at a time and then move them to the front or the top where you need them. As the FUEs existed up until just a few years ago, most of these men had most of their donor area shaved, which is the gentleman on the right of these photos. It's very scary and kind of dramatic looking, but that was really the only way. The instrumentation didn't exist to be able to do it any other way. The no shave is the gentleman on the left, where you literally are extracting at full length without shaving the back of the head. The existing hair is preserved. You don't need to shave off the other hairs. The natural hair camouflages with the transplanted area where the hairs were removed. And you walk out of this office and nobody would know you had a hair transplant, at least from the back. Anywhere the hairs are placed in the front, you will see, you know, the areas where the hairs have been transplanted into, but the donor area looks totally normal. It's actually very remarkable and exciting. Not every surgeon does this. It's important to ask that question. Not every hair transplant surgeon has been trained in this. More and more are getting trained, but we've been doing it for a while. Okay, pre and post-op optimization of hair growth surrounding the hair follicle. This was a big topic at the conference, which was great because you know, a lot of men come in and say, I want a hair transplant, but they've been losing their hair for a few decades, but they really haven't addressed some other treatments that might be also helpful. That's not to say it's going to eliminate the hair transplant, but we do know that these other types of treatments can stimulate and improve the growth of the hair transplant. It's a supportive therapy. So I've listed them here. The microbiome balance, we're going to talk a little bit about that because androgenic alopecia patients have an imbalance of their types of bacteria on their scalp, which is an interesting fact. But it may be helpful to use that ketoconazole shampoo, which helps to optimize the normal bacteria just before and maybe a little bit after surgery. Nutritional assessment. If you're going to have a hair transplant, I'd like to know what your vitamin D level is, you know, especially the vitamin D, because we don't get enough sunlight here. Most men, their B vitamins and ferritin are okay unless they are vegetarians or have had recent weight loss. PRP treatments does enhance the growth and decreases the shedding that sometimes can occur post-hair transplant. It improves the scalp health, it stimulates cell activity. That's the beauty of PRP. It does a lot of these other things, creates a much more optimal environment for transplanted follicles. We tend to do more and more PRP surrounding the hair transplant procedure because we know based on research that it does help. Medical therapy, adding medications to the treatment plan. These DHT blockers, finasteride, dutasteride, as well as minoxidil orally to stimulate growth, these can protect the non-transplanted hair and may also improve the growth of the hair that's being transplanted. So it always makes me sad when somebody comes in and says, I want just this done. And I understand, you know, they may be reluctant to take medications or they don't want to deal with other stuff. But in fact, if you want the best an optimal treatment and result from what you're investing in time, energy, and money, you need to think about other supportive therapies. The other thing is, in men, you still have to rule out these other causes of potential hair loss. Less common in men than women, but men come in, have a hair transplant, one area is not growing. We do a biopsy and find out that one area has alopecia areata. We are seeing more scarring alopecias with men. We rarely saw it before. Also, if the scalp is infected with seborrhea, it's not going to be it's not going to be healing enough to have a good transplant, and it's not going to accept it as well. These things are also very important, which is why doing the examination before the surgery is so important. I feel like a broken record. That's the messaging. Eyebrow transplants. This is something that's absolutely exploding. It's growing in popularity. Men and women, thicker brows are in vogue again. Women for decades overplucked. With aging, your eyebrows tend to thin. Very common. But again, eyebrows in men and in women thin out with age, and some men are coming in for this as well. It's, again, you need a very well-trained technical surgeon who knows how to do this well, because of all the hair transplants, it's so important to put them in the right angle, in the right spacing. It takes a careful donor selection. The hair needs to be taken from the scalp, literally in the area where the hair looks most like the eyebrow, in thickness and in texture. Usually it's behind the ears, not typically in the back like you do for a scalp transplant. The success rate for eyebrows is usually about 90% of the transplanted hair will grow permanently. Maintenance is needed. They continue to grow. Unlike your typical eyebrows, they grow very fast and they need to be maintained. A little bit about cell regenerative therapy. This is a hot topic. A lot of people come in asking about it. We're talking about stem cells, exosomes. Cell regenerative therapy represents the cutting edge of hair restoration. It harnesses your own regenerative capabilities, your own cells, to stimulate follicular growth. It refers to a method of mesotherapy. That means something is actually injected or infused into the tissue around the hair follicle, which utilizes either the patient's own tissue, which is called autologous, or donated tissue, which is called allogenic, to stimulate follicular growth. It's important to understand that as of right now, today, using allogenic tissue, meaning somebody else's tissue, for mesotherapy treatment for hair loss is not allowed in the United States. This includes somebody else's stem cells, somebody else's exosomes collected from another person. So how can we get regenerative therapy? Well, we get it from our own. And there were some studies that were discussed in this conference that I went to, where they literally take samples of their patient's own follicle stem cells and process it. They pluck the hairs, they process the follicle. Around the bulb of the follicle are stem cells, exosomes. They process it into a serum. It's packed with growth factors from the stem cells, and this serum has an incredibly high concentration of growth factors, stem cells, and exosomes. They are the patient's own tissues. So you don't have to worry about all the concerns that we have getting something from somebody else, particularly diseases or infections, which again, that was the big concern. How are the exosomes from somebody else being processed? There was no standard, and that's why the FDA said no. So, but this is your own, and it's very exciting, and I think it really represents the future of hair restoration therapy, or at least part of it. Again, part of it. A little bit about the microbiome. I'm not going to spend a lot on it, but it's a hot topic. Microbiome is the diverse community of microorganisms. It's bacteria, fungi, and viruses. They interact on the physiology of the host and contribute to the health and disease of the patient. Dysbiosis is a term used to describe a condition when the bacteria are out of balance. We know that dysbiosis decreases the resistance to disease, creates an environment conducive to inflammation and tissue damage. There's more and more research being done, which has shown to us that even the gut microbiome and the scalp microbiome, when they're out of balance and abnormal, scalp tissues can occur, and they can cause hair loss. This balance is increasingly recognized as fundamental to hair health. There's this gut-hair connection. It seems crazy. Why would the gut being out of balance cause hair loss? But in fact, it is showing that when you have this dysbiosis, this imbalance, the gut is more permeable. You know, we do absorb our nutrients normally, but when it's unhealthy and the gut's unhealthy, other things can get absorbed, potential toxins, and it can lead to inflammation in the body as well as hair loss. There's a strong correlation between alopecia areata, which is the big spots of hair loss or the complete hair loss, and ulcerative colitis, which is another autoimmune disorder where there is a gut immune hair connection. People with alopecia areata are more likely to have ulcerative colitis, and the reverse is true. If you have ulcerative colitis, you're more likely to develop alopecia. It's a fascinating topic, a lot of research being done, but what we know is, you know, when you have this leaky gut, it leads to gut dysbiosis, and toxins can enter your body and cause chronic inflammation. So additionally, poor absorption of vitamins and nutrients due to the gut dysfunction, we know can affect hair follicle health. So what are my recommendations for maintaining microbiome health? Scalp care. Considered a couple things. As I mentioned before, androgenic alopecia has a bit of an imbalance of the normal bacteria, which is interesting. And they actually have followed that the patients who had the worst imbalance of their bacteria on their scalp were more likely to develop a worse case of androgenic alopecia. So ketoconazole shampoo, maybe once a week for patients with androgenic alopecia. It actually helps keep that balance and the scalp microbiome in place, provides anti-inflammatory. There can be a place for pre and probiotics. It helps maintain good gut health, particularly in patients that have inflammatory hair loss. An anti-inflammatory diet. I personally think everybody should be on an anti-inflammatory diet, but in any case, the Mediterranean or anti-inflammatory diet will help support your gut health, will help support to help decrease systemic inflammation. Some research on adding soy to your diet may help block the DHT and support hair health, particularly in androgenic alopecia. And then protein. Most interesting studies have shown that most androgenic alopecia patients have very low protein intake. I don't understand why, but that happens to be the case. So we want you to aim for adequate protein consumption to support hair strength and growth. Hair is made up of protein. If you don't provide that, it doesn't grow well. All right, here's a hot topic, GLP-1 drugs. Does it cause alopecia? I'm gonna go through this quickly because I wanna leave a little bit of time for questions, but the answer is yes and no. We know that these medications help regulate glucose secretion from the liver. They delay glucose absorption in the gut. They decrease hunger and people lose weight. You've all heard about them. Semaglutide, the Ozempic, Wegovy, Mounjaro, Zepbound. I can't tell you the percentage of patients who come in here on these meds, but it's so high now. Do they cause hair loss and alopecia? It's not that simple. It's not a simple question to answer. There've been I'm not going to go through this much, but there are multiple studies looking at whatever has been looked at in terms of this correlation between GLP-1 medications and hair loss. And the bottom line is these studies are terrible. There's not enough information. They don't even describe what type of hair loss they were experiencing while they were on these drugs. They didn't even have good sample sizes. Follow-up was variable. They didn't sometimes even tell us what kind of, which of the medications they were on. So very few conclusions can be drawn by the studies as they exist today. And these were all done within the last year. What do we know? What we have observed is that most people coming in with hair loss on these medications, it looks a lot like a telogen effluvium, which is that excessive shedding that occurs. It also can look like a bit of androgenic alopecia. This suggests that the medications may be triggering a hair cycle disruption, which is what happens with telogen effluvium. Instead of growing for a long period of time for years, that gets disrupted and the hair sheds. They know that the more degree of weight loss a person experiences and the rapidity with which that occurs will result in more loss. We saw this when patients used to get bariatric surgery. They lost a lot of weight in a short period of time. They were shedding their hair. And these patients were on a lot of, they were being monitored very carefully with their diets, and it still happened. It was really how fast that how fast that weight loss occurred. Unfortunately, most people that are on these GLP-1 medications are not being monitored at all. There are hormonal changes that can occur with these medications, including decreased estrogen production and thyroid imbalance. Stress, a lot of these people on these meds are feeling so stressed by what they're going through. The stress alone can cause shedding. The alterations in diet. A lot of these side effects of these medications include nausea, abdominal pain, diarrhea, changes in types of food being consumed. It may result in hair loss, that gut-hair connection we talked about. So interestingly enough, there can be some potential benefits to these medications. So even though we do see people shedding, and I do believe it's more like a telogen effluvium, there are some patients who were taking these medications initially for diabetes, and when their metabolic changes and abnormalities improved and their diabetes improved, then their hair actually grew better. So that has created some big question marks. It's been looked at, these medicines have been looked at in treating patients with scarring alopecia, that maybe some of these patients are seeing some benefit. The inflammation is being reduced, but that's probably a different cause of hair loss than what we're seeing with the rapid weight loss that people experience with these medicines. Everyone agrees more research is needed. It's a complex problem and it needs to be evaluated. My recommendation for GLP-1 users, focus on good nutrition. Get your protein. Get your labs checked. Check your check for nutritional deficiencies. It's very important. If you're losing your hair and you're on these medications, seek expert evaluation. See an expert. Interestingly enough, in those studies, even though they were terrible studies looking at it, there were noted patients who were having alopecia areata, scarring alopecia, psoriatic alopecia, which need a whole different type of treatment than alopecia areata. The good news is, if you're getting examined and none of those immune abnormalities exist, most patients, if you stabilize the nutritional deficiencies, once the nutrition and weight loss is stabilized, the hair loss generally stops and regrowth is possible. A small percentage don't. And if they don't get better, then they might need treatment to help stimulate the regrowth, either minoxidil or low-level laser therapy, and sometimes PRP could be considered. All right, I'm going to take 2 minutes to talk about social media and hair loss, because I think this is a huge topic. I'm just going to quickly go through this, but there was a study done that was looking at women and how much money they spent on their hair loss. Buying products online, buying products at the pharmacy. The costs ranged from anywhere from $50 to several $1,000s a year. And most of these treatments were not recommended to them by their hair loss specialists. This was just stuff they were buying on their own. The marketers will spend billions of dollars trying to get you to buy their product. I can't say enough that you need to have your scalp examined to find out what is really wrong with it. I was online. I took this survey from this one product was being sold online. And I took this 5-question survey, and it told me at the end of the survey that I had the scalp of a 146-year-old woman. Well, I'm not that old and my scalp is not dead. It told me if I used their serum, it would get better. Their serum had over 30 different things in it, 30 different ingredients. I was shocked. The truth about scalp aging is collagen production does decrease. Moisture decreases. That's what the hyaluronic acid is. Epidermal thickness decreases. Stem cell function decreases. Circulation to the scalp decreases. There are treatments for all of these things. We can do things to make these things better, things that have been studied and approved and known to have benefit. The only way you're going to know what you really need is to have a proper diagnosis and medical supervision. There's no miracle serums out there. People are wasting thousands of dollars on things that don't have any science behind it. And unless somebody has looked at your scalp, they're not going to be able to know what it is that you really need. All right, that's my message. Get a good examination. Let somebody look at your scalp, get appropriate treatment, be appropriately evaluated, and get what you really need. Thank you. It's a lot. I kind of rushed through it. I apologize for that, but I did want to leave a little bit of time for questions. We will be sending out an email after the webinar to anybody that's interested in having a consultation. If that doesn't happen for whatever reason and you want to contact us with a question, there's our email address. Because of the size of the people on the webinar today, I probably am not going to be able to answer all your questions. And this has happened in the past, but what I will promise to do is whatever questions I don't answer, we keep a copy of them. I will answer those questions and send all of the questions and answers out to everybody who signed up for the webinar. Your names will not be on it. It'll be just the question and the answer. Please give me a couple of weeks to do it because it usually is a fairly long list of questions. So I'm going to try not to lose you. I'm going to put myself up here. Okay. I don't know. I may need some help finding the Q&As. Give me a second here. I get my tech guy in to help me. Where are they? Oh, okay. Great, thank you. And again, thank you for joining me. I will do my best to get through some of these. Somebody asked examples of people we haven't been able to help and why. That's a great question. It's a very small number of people, but I thinking off the top of my head, there's probably over the course of, I have to move back, over the course of, almost 15 years of doing this, I can count on probably one hand the number of patients who got no benefit. And those patients are really heartbreaking. A couple of them are very young. We tested them for a lot of things. We did multiple scalp biopsies, tested them, treated them with everything that we know could be a benefit, and a few things that we, were a bit experimental as well. Some patients come too late. That is a part of the problem. If a patient comes and their hair loss is very profound, we're less likely to get any significant benefit. And it's heartbreaking. Scarring alopecia can sometimes be extremely difficult to treat. Usually we can get things a little bit better on most patients, truly, and get some regrowth, but there's a certain percentage that just don't get better. It's a very aggressive disease. That's why I'm so excited about the JAK inhibitors and the research being done on scarring alopecia, because it may change the lives of a lot of women who suffer with this diagnosis. Somebody asked alopecia fibrosis. Alopecia fibrosis, I think, is probably a term somebody used with you for scarring alopecia. It's not the same as alopecia areata. Alopecia areata, the hair follicle is not destroyed. It's there. It's just being shut down by, it's an autoimmune disorder, our own bodies. It's very complicated, but the good news is research is figuring this out, and there's better treatments for alopecia areata today, the JAK inhibitors particularly. Fibrosis is more the scarring alopecia. We don't know what causes it. Again, is it something we're putting on us, something we're putting in us? Is it, our bodies, we are experiencing in this world now so much inflammation, autoimmune diseases. They are skyrocketing, and we don't know all the reasons for it. But the good news is there is more research, and hopefully we'll have better answers in the future. So this is a question. I am in menopause. Should I take HRT? I'm not the person to ask that question. Your primary care doctor should, or your gynecologist should answer that. Our HRT can help hair, but it's not safe for everybody. It's safe for a lot of women, but not for everybody. So you really need to speak to your doctor who knows you well, who understands your other medical problems to decide if it's really safe. Is the presentation being recorded? Yes. It will be on our website, but it probably takes a couple of weeks for that to happen. Sometimes it ends up on YouTube, but it will be recorded. It will be on our website probably in a couple of weeks. You've heard that ferritin could be in normal range, but still not sufficient for hair growth. That's absolutely true. Ferritin has a wide range of what's considered normal. Anywhere from about 30 to 100 or more can be considered normal. 30 is considered low for hair. If your hair is thin and shedding and your ferritin is 30 or less, even though 30 might be considered normal, we would recommend iron supplementation until that level got to be about 50 or better. Somebody asked about biotin. Biotin, hot topic. In people who are deficient in certain nutrients, biotin can be helpful. I did not go through lists. We don't measure biotin levels. I'm not even sure they can be measured in the labs. But biotin is a B vitamin, and like a lot of B vitamins, it is helpful in growing healthy hair. The B vitamins in particular are helpful for keratin formation and growing certain parts of the hair follicle. So it can be helpful. The problem with biotin is the doses are so high in most supplements that it can affect certain blood tests. So if you're on a hair supplement with biotin and you need to have blood work done, you need to stop the biotin for about a week before, particularly thyroid medications. If you're taking them, it can change the blood test. It doesn't change the effectiveness of your medication. it affects the blood test. It's very bizarre, but there probably is benefit for people who have nutritional deficiencies. Can stress cause hair loss? Absolutely. Absolutely. It's one of the worst causes of hair loss. And if so, does hair regrow when the stresses are gone? Yeah. Yeah, they can. And you know, I've seen a lot of women come in with severe shedding unrelated to weight loss, just severe stress, family stress, illness, financial stress, death of a loved one. Those are the kinds of things that can cause hair shedding. And usually, you know, we check for blood work, make sure nothing else is contributing, treat what we can treat, and generally with time, it will stop. It takes about a year. It's hard to sit and wait and be patient. But the shedding can last 6 to 12 months, and then then the recovery starts. That's the good news. Is there a known difference between efficacy between topical and oral minoxidil? Thank you for asking that question. I don't know. I probably glossed over it a little bit. Most research shows they're probably equally effective, but I will tell you that probably higher doses of minoxidil may be a bit more effective, which is why this newer formulation of the higher dose extended release may in fact, it did on the research protocols show increased benefit, most likely related to dose. So if you were going to take, you know, the regular low dose minoxidil, which is the 0.6 milligrams up to 2 to 5 milligrams, it works equally well to the minoxidil topical if you take the topical minoxidil twice a day. Very few people do, but it is probably equally effective if you will commit to the topical minoxidil twice a day. Somebody asked about, does insurance cover these treatments? The answer is insurance will cover your blood work most of the time, will cover your medications most of the time. Insurance rarely, if ever, covers treatments for like surgery or some of the other treatments. They consider it cosmetic, even though some of these women are suffering horribly with hair loss. Some people do use their flexible spending accounts that they have, the FSAs, through their employer. Once in a while we'll get something covered, but I will tell you, I've even had teenage girls who lost their hair from cancer and their insurance companies refused to pay. So, but medications, blood work, and some treatments in very special situations can be covered, but it's very individual. But a lot of it is not covered. Sublingual minoxidil, even though again I mentioned that it's not available commercially yet, it's literally something you put under your tongue and it dissolves within a minute. It just gets absorbed very quickly into the bloodstream, does not need to be metabolized into the gut. So it bypasses the whole liver thing, and so it decreases the kind of side effects you're going to have. It works very quickly. I'm not sure when it's going to be commercially available. That was not mentioned at the presentation. Somebody asked, they had trichoscopy done years ago. Should it be repeated? Yes. I mean, we do repeated trichoscopies sometimes multiple times a year if someone's, you know, has an inflammation, particularly our scarring patients or somebody with seborrhea or some kind of inflammation going on. We want to see if they're getting better. That's the only way you're going to know. A lot of these things you can't see with the naked eye. You can't diagnose them with the naked eye. Even if I did like a video consult with you, if I couldn't see your scalp, I couldn't truly make a good diagnosis. Why does ketoconazole shampoo need to sit on the scalp for 8 to 10 minutes? It needs to get absorbed. You're giving it time to be absorbed. If you just shampoo your hair and rinse it out immediately, you're just doing a shampoo. The ketoconazole or the nizoral is really a scalp treatment in the form of a shampoo. So there are other types of scalp treatments that do come in shampoo form because it's easier to get to the whole scalp that way. They really aren't. They do clean your hair, but they're really meant to be a scalp treatment, which is a skin treatment of the head. So you need to let it sit for 8 to 10 minutes so it can be absorbed to the level of the hair follicle, and then rinse it off. And then use a really good conditioner because it dries your scalp out. I mean, excuse me, not the scalp, it dries your hair out. How effective is taking a collagen supplement? The jury's out on that. It may have some benefit, but in truth, there's not been enough research to compare it to other types of treatments and other types of supplements. What you really need is protein. You need good protein to give the body what it needs. Collagen is a form of that. And so it probably can have some benefit, and some research, early research has shown that it may has some benefit, but it's not, you know, a wow thing. I would use it as an additive. I wouldn't count on it to do a major benefit for you. Why aren't women included in studies from the start? Why does it have to wait until a drug is approved for men? Oh man. This has been the world of medicine for centuries. This was true of a lot of meds for many years. Cardiovascular medications, cholesterol medications, high blood pressure medications, you know, unless it was a cancer treating something that was only in women, most things were studied in men first. It's just a bad way of doing it. I will tell you now, things are changing. And so the medications, what I mentioned, were only studied in men were because there may have been some concern about negative side effects for women, particularly testosterone blockers. If a young woman utilizes a testosterone blocker when she's pregnant, it can affect the baby's sexual organ development. And so for those reasons, that's a legitimate reason not to test it on women. The finasteride, dutasteride, which, you know, I mentioned can only be postmenopausal women, they have been studied on postmenopausal women. They're not going to likely ever be studied on premenopausal women. What brand of shampoo do I recommend? I recommend a very natural shampoo without fragrance, without unnecessary additives. Sulfates, some people are sensitive to them, but I'll tell you that sulfate has a place once in a while because that's what really cleans and the scalp and gets the dirt off the hair. But again, because a lot of people are sensitive to it, they have taken that out of a lot of shampoos, which is fine. But I tell people about once a month, you should use a sulfate shampoo. Do you offer testing to measure microbiome levels? I don't. That's all being done under experimental protocols. It has been done. And if you're interested and want to see those studies, I can get them for you, but we don't do it. It has to be a very special lab done under experimental protocols. Vitamin D, ferritin, and other, you know, vitamins. Yes, almost any lab can get that done, and we order them all the time. We don't do them here, but we do order them. You heard PRP and exosomes don't work for older people. I will say that that's not entirely true. The reality is you need to start treatment as soon as possible when you first start seeing your hair thinning. We do have success with older women and certainly men as well. And I've seen some women who I didn't think would get any result, elderly women in their 80s who did. So it's hard to predict, but the bottom line is because of those things that occur with age, you know, the thinning of the skin, the less effective stem cells, you know, but all those things are helped with PRP. So I wouldn't say never do it if you're, you know, significantly older. I'm well over 65. I do all those treatments to help my hair. I have moderate androgenic alopecia. Those things I believe help. We don't do exosomes other than what your own body produces. Somebody asked about the slides. They will be on the webinar. The webinar will be on our website in about 2 weeks. Yep. Somebody asked about 5 milligram finasteride, which is used for prostate disease, work as well as 1 milligram finasteride. It probably works better. It's a dose thing. All you need is 1 milligram for androgenic alopecia. You don't need 5 milligrams for androgenic alopecia. If you're on 5 milligrams for prostate disease, it's probably helping your hair if you have AGA. Telogen fluvium, somebody asked about the causes. The list is long. Illness, hormonal imbalance, stress, vitamin deficiencies, rapid weight loss, illness, I said that already, surgery. It's a long list. All of those things play a role. Most people who have a telogen fluvium, if it's not illness or nutrition related, if you don't have nutritional deficiencies, if you don't have an underlying illness, if it's due to stress and you're nutritionally intact, your hormones are okay, hormonal imbalances cause telogen fluvium as well, thyroid disease. If those things are all corrected, most telogen fluvium will resolve on its own. Some patients don't, a small percentage don't. And in those cases, we then consider minoxidil laser, sometimes PRP. But the vast majority of people, if you can correct what the problem is, the telogen effluvium will resolve. Somebody asked, do we do work on gut issues? The only thing that I would tell you is we don't do gut microbiome testing, which can be done. It's being done experimentally under research protocols. And I think probably some gastroenterologists, who specializes in this problem, do. What we do is, in terms of your hair, we do recommend pre and probiotics, particularly in women who are on weight loss programs, or someone who has been chronically ill. But we don't treat their gut issues primarily, and we focus on the hair. Somebody asked, they're taking Minoxidil 2.5 milligrams a day already with the addition of a product like Nutrafol help. The answer is probably, yeah. A lot of questions. I'm going to give this like 3 more minutes. It'll be 8:10 there, and I'm going to stop. Like I said, I am going to answer all these questions and get them all back to you without your names on the questions. So just bear with me. I'll try to get to a few more. This is a long one about finasteride, dutasteride. Okay, somebody asked if you use finasteride or dutasteride and you're blocking the DHT and your hair starts to improve, the follicles plump up a bit and start growing a better quality hair, can you stop these medications but retain the benefits? No. As I said before, much like any medical problem, and this is that, you can't cure it with medication. You only treat it. You'll probably hold on to the benefit for maybe 6 months. The same is true of minoxidil, laser, PRP. You'll hold on to your benefit for 6 to 12 months, and then you will lose it, unfortunately. Can you speak to research-backed natural DHT blockers such as rosemary essential oil? Rosemary was actually studied. It was found to work as effectively as minoxidil 2% once a day. Well, the reality is nobody recommends minoxidil 2% once a day. It's too weak. The benefits are minimal, but it did work as well as that. Does it have some benefit? Probably a little. There are many natural ingredients that do have benefit, and I'm not saying none of them help. They're just probably not as strong as what we do know works. And then nobody's done the research really to compare them to the best treatment that's available. If that were done, I would be thrilled, but that research has not been done. Derma rolling or microneedling actually can stimulate a little bit of growth. I would tell you that some of the traditional PRP that we do with needles does include a microneedling treatment. Some patients do microneedling at home with some of the serums with like minoxidil. It does have benefit. I just don't know how far it will take you, but it's certainly something that can be done at home. It does give a little bit of increased blood flow. It can stimulate a little bit of growth, but it's generally used in conjunction with other things. All right, 1 more minute. Somebody asked about, again, microneedling. All right, some of these. Again, a question about, PRP, stem cell therapies. Are you one and done? And the answer is no. I mean, even the initial series of 3 with PRP, when you get some of the benefits of stem cells, or the treatments that were being researched with your own stem cells and your own exosomes, those type of treatments you may not need as often. We don't know the answer to that yet, but it's still going to need continued ongoing treatment because you have to continue to stimulate that hair follicle. If you stop stimulating that hair follicle, if you stop with the medications that are keeping it alive, you're going to lose it. And it's heartbreaking. We see people come in all the time. They went through the whole process. They maintained their treatment for a good year or 2, and then, you forget about it. Life happens, stuff happens, gets in the way. And they come back, 4 or 5 years later, and we're back to square one. So I can't stress that enough. If you're going to do treatment, you got to commit to it. It's really lifelong. I've been doing, my grandmother wore a wig by the time she was my age, so I've got full head of hair. It's not 146 years old, but I just have to continually work on it. It's not going to, if I stop, I will be much thinner. So I just want to thank you all. Oh my gosh, this has been an incredible evening for me. The questions are great. I will answer every single one of them. I promise you. I will get them back to you. Your name will not be on the question. It'll be anonymous, but all the questions will be answered, and we will send them out to the entire list of email addresses that we have that you signed up for for the webinar. I appreciate you taking the time to be with me this evening. I'm so excited about where the treatments for hair loss is going. We have our standard, we know it works and it works well, but it's great to know that there's more treatments happening, particularly in the scarring alopecias and improving the medications that we're already using. These medicines work, but can they work better? And the answer is yes. And so there's a lot happening. And so I keep yourself well informed, send us some questions. We would love to see you here, get a good look at that scalp, really get you the treatment that you need. And again, thank you so much for taking the time to be with me this evening. Thanks.